I have something I need to say that I have been carefully choosing the right moment to say for a very long time. Every single week in my clinic, I see patients who are quietly destroying their kidneys, their stomach lining, and their cardiovascular system, not with junk food, not with alcohol, not with neglect, but with a little orange pill that their previous doctor told them was perfectly fine to take every day, ibuprofen. And the reason I have waited this long to make this video is because the pharmaceutical lobbying around NSAIDs, non-steroidal anti-inflammatory drugs, is aggressive, and the cultural dependence on these medications for chronic pain management is so deeply embedded that saying what I am about to say can feel like professional heresy. But you deserve the truth, and the truth is this. If you are over 60 and you are taking ibuprofen regularly for chronic pain, you are trading short-term relief for long-term damage that may not be reversible. My name is Dr. Ming Chen. I am an integrative medicine physician with 24 years of clinical experience, specializing in pain management, inflammation, and the intersection of conventional and traditional Chinese medicine. And today I'm going to give you 6 specific alternatives that Chinese medicine has used for centuries to manage chronic pain. Alternative that modern pharmacological research is now studying with remarkable seriousness. Alternatives that work through mechanisms that do not compromise your kidneys, do not ulcerate your gastric lining, and do not elevate your cardiovascular risk. This is not about choosing between modern and ancient medicine. This is about understanding which tools actually serve your body over the long term. Let me start with why ibuprofen is so dangerous for people over 60 specifically, because this part is not widely communicated and it should be. When you take ibuprofen, it inhibits an enzyme called CoX, cyclooxygenase, in 2 forms, COX-1 and COX-2. COX-2 inhibition is what reduces inflammation and pain, but COX-1 inhibition is what causes the damage. COX-1 is responsible for producing prostaglandins that protect your stomach lining, maintain healthy blood flow to your kidneys, and regulate platelet function. When you suppress COX-1, you remove that protection. For a 30-year-old taking ibuprofen occasionally, the system recovers. For a 65-year-old with already diminishing renal reserves, already reduced gastric mucosa thickness, already elevated cardiovascular baseline risk, the calculus is completely different. A 2019 analysis published in the British Medical Journal followed over 440,000 patients over 60 and found that regular NSAID use was associated with a 44% increased risk of acute kidney injury compared to non-users. A 2016 meta-analysis in the European Heart Journal found that even short-term use of ibuprofen, as little as 1 week, was associated with a significantly elevated risk of myocardial infarction. The FDA itself updated its warning labels on NSAIDs in 2015 to state that the risk of heart attack or stroke can occur as early as the first weeks of using an NSAID, and yet these medications remain among the most casually recommended over-the-counter drugs in existence. The gap between what the research shows and what the culture communicates is enormous. Think of chronic inflammation like a fire in your house. Ibuprofen is a bucket of water thrown directly at the flames. It is effective in the short term, but it does not address why the fire started. And if you keep throwing that same water, which happens to be slightly corrosive, on your floors and your walls every day, eventually the structure of the house itself begins to weaken. Traditional Chinese medicine understood something fundamentally different about pain. It saw pain not as a problem to suppress, but as a signal of imbalance, specifically of what it called Bai syndrome, or painful obstruction syndrome, where the flow of qi and blood through the body's channels becomes blocked. The goal was never to silence the signal, The goal was to restore the flow. And restoring the flow, it turns out, is almost exactly what anti-inflammatory nutrition and herbal medicine accomplish at the biochemical level. Let me give you these 6 alternatives, and as with everything on this channel, I am going to give you the mechanism, not just the name, because understanding why something works is what transforms information into lasting change. The first alternative is turmeric, specifically its active compound curcumin. I know you have heard of turmeric. I know you may have already dismissed it as a wellness cliche. But I need you to set aside whatever you think you know and look at the actual pharmacology. Curcumin inhibits NF-kappa B, nuclear factor kappa B, which is the primary molecular switch that activates the inflammatory cascade in your body. It also directly inhibits COX-2, the specific enzyme that ibuprofen targets, without touching COX-1. That distinction is everything. A 2014 randomized controlled trial published in the journal Phytotherapy Research compared curcumin to ibuprofen in patients with knee osteoarthritis and found that curcumin performed comparably to ibuprofen on pain scores and functional improvement, with significantly fewer gastrointestinal side effects. The curcumin group actually reported better tolerability across all measures. The critical issue with curcumin is bioavailability. Curcumin on its own is poorly absorbed. You need to consume it with black pepper, piperine, which increases absorption by up to 2000%, or in a lipid-based formulation. A therapeutic dose in studies ranges from 500 to 1000 milligrams of curcumin extract daily, which is not achievable through food alone. You need a standardized extract with piperine or phospholipid complex formulation. Plain turmeric powder in your cooking is beneficial, but it is not therapeutic dosing. The distinction matters. The second alternative is corydalis, called yanhusuo in Chinese medicine, and this one is genuinely extraordinary and almost completely unknown in Western medicine. Corydalis yanhusuo contains a compound called dihydrocorriborabine, or DHCB, which was identified and isolated in a landmark 2014 study published in the journal Current Biology by researchers at UC Irvine. DHCB works by blocking dopamine D1 and D2 receptors in a way that interrupts both acute and chronic pain signaling. The researchers described it as having a unique analgesic profile, unlike any existing pain medication. Unlike opioids, it does not create tolerance or dependence. Unlike NSAIDs, it has no COX inhibitory mechanism and therefore no gastric or renal toxicity. It has been used in Chinese medicine for over 2,000 years for what classical texts called blood stagnation pain, sharp, fixed, severe pain, which corresponds closely to what we now understand as neuropathic and chronic musculoskeletal pain. I want to tell you about a patient named David. He was 64 years old, a former construction foreman from Seattle. He came to me with chronic lower back pain that he had been managing with 800 milligrams of ibuprofen 3 times a day for almost 4 years. His kidney function was already showing early signs of strays. His gastroenterologist had identified early erosive gastritis. He was, in other words, paying an enormous biological price for his pain management. We transitioned him to a protocol that included corydalis extract alongside 2 other approaches I will describe in a moment. Within 6 weeks, he had reduced his pain scores from a 7 to a 4 on a 10-point scale. Within 4 months, he was off ibuprofen entirely. His GFR stabilized. His gastric symptoms resolved. He told me he felt like he had stopped fighting his body and started working with it. That is the language of someone who has crossed from suppression to restoration. The third alternative is Boswellia serrata, called Ruxiang in Chinese medicine, and this one has some of the most compelling clinical trial data of any herbal anti-inflammatory. Boswellia works by inhibiting 5 LOX, 5-lipoxygenase, a pro-inflammatory enzyme that is actually not targeted by ibuprofen at all, meaning Boswellia and conventional NSAIDs are addressing different branches of the inflammatory pathway simultaneously. A 2011 randomized double-blind placebo-controlled trial published in the International Journal of Medical Sciences found that a specialized Boswellia extract called aflapin significantly reduced pain and improved physical function in osteoarthritis patients within 5 days. 5 days. The effect size was clinically meaningful and sustained over the 90-day study period. Boswellia also specifically inhibits the breakdown of cartilage, something ibuprofen does not do and may in fact worsen with long-term use, since prostaglandins play a role in cartilage maintenance. In Chinese medicine, ruxiang, frankincense resin, has been prescribed for arthritis, trauma pain, and what practitioners call wind-cold dam obstruction in the joints for centuries. It was always paired with mo yao, myrrh, to amplify the blood-moving pain-relieving effect. Modern research is now examining this classic combination and finding synergistic anti-inflammatory activity, exactly as classical practice predicted. The fourth alternative is white willow bark. And yes, this is the original aspirin. Before Bayer synthesized salicylic acid in 1897, willow bark was the analgesic. But here is what most people do not know. Whole willow bark extract works differently from isolated salicin. The additional compounds in the whole plant, flavonoids, polyphenols, additional salicylate compounds, create what pharmacologists call an entourage effect, where the combination is more effective and gentler than the isolated molecule. A 2001 trial in the American Journal of Medicine comparing willow bark extract to conventional analgesics in chronic low back pain patients found comparable pain relief with a significantly better side effect profile. The gastric irritation associated with aspirin is substantially reduced with whole willow bark because the salicin is metabolized into salicylic acid gradually after absorption, rather than arriving as an already converted irritant in the stomach. Now I need to pause here and be very clear about something. White willow bark is not appropriate for people who are already on aspirin therapy or blood thinners, and it should be avoided in people with aspirin sensitivity or active gastric ulcers. I'm not presenting these alternatives as having zero contraindications. Every pharmacologically active substance has considerations. What I'm saying is that the risk profile of these botanical alternatives is dramatically more favorable for most people over 60 than daily NSAID use. The fifth alternative is something that very few people outside of Chinese medicine circles have heard of, noto ginseng root called sanqi or tianqi. This is one of the most prized herbs in the entire Chinese pharmacopoeia, historically more valuable by weight than gold during certain dynasties. It contains saponins, specifically notoginsenosides, that have potent anti-inflammatory and analgesic activity, and uniquely anti-hemorrhagic properties simultaneously. Modern research has shown that noto ginseng modulates TNF-alpha, tumor necrosis factor alpha, and interleukin-6, two of the primary cytokines driving chronic inflammatory pain. A 2020 study in the Journal of Ethnopharmacology demonstrated that noto ginseng extract significantly reduced pain behaviors and inflammatory markers in animal models of both acute and chronic pain, with a mechanism distinct from NSAIDs and with no observed gastric or renal toxicity. What is particularly relevant for older patients is noto ginseng's dual action on blood circulation. Chinese medicine described it as stopping bleeding while simultaneously moving blood, an apparent paradox that makes complete sense once you understand that healthy microcirculation actually reduces both bleeding tendency and stagnation-related pain. For patients with joint pain, muscle pain, or pain from old injuries, what Chinese medicine would describe as blood stasis, noto ginseng is often the single most targeted intervention. I typically recommend working with a practitioner familiar with Chinese herbal medicine to dose this properly, as it has significant pharmacological activity and should be introduced thoughtfully. Before I give you the sixth and final alternative, I want to check in with you because I know this is a lot of information and I know some of you came to this video in real pain, chronic, daily, limiting pain. And you may be wondering if any of this is actually going to help you. I want to look you in the eye, metaphorically, and tell you, yes, not as a promise, as a clinical observation from 24 years of watching patients transform their relationship with pain when they approach it with the right tools. How many of you have been taking ibuprofen or another NSAID for more than 3 months? If that is you, leave a comment below. Tell me what you are managing and how long you have been at it. You are not alone and there are answers. And if this kind of content is reaching you where you needed it, please give the Dr. Ming Chen channel a like and subscribe. It genuinely changes how many people this information reaches. The sixth alternative is not an herb, it is a practice. And I am including it here because no conversation about chronic pain alternatives is complete without it, and because the research behind it has become so robust that to omit it would be a disservice to you. Acupuncture, specifically electroacupuncture for musculoskeletal chronic pain. I know acupuncture occupies a complicated space in Western medicine's estimation. I also know that in 2017, a landmark meta-analysis published in the Journal of Pain, one of the most rigorous pain research journals in existence, analyzed individual patient data from nearly 21,000 patients across 39 high-quality randomized controlled trials. The conclusion was unambiguous. Acupuncture is significantly more effective than both sham acupuncture and no acupuncture controls for chronic musculoskeletal pain, osteoarthritis, headache, and shoulder pain. The effect sizes were clinically meaningful and durable, persisting at 12-month follow-up. This is not anecdote. This is high-powered meta-analysis. The proposed mechanisms are now fairly well understood. Acupuncture stimulates the release of endorphins and enkephalins, your body's own opioid-like molecules, activates descending pain inhibitory pathways in the spinal cord, reduces local inflammation through neuropeptide modulation, and improves blood flow to affected tissues. Electroacupuncture, where a mild electrical current is applied through the needles, amplifies these effects, particularly for nerve pain and deep musculoskeletal pain. For patients who cannot access or afford regular acupuncture, acupressure at specific points, particularly large intestine 4 on the hand, stomach 36 below the knee, and spleen 6 above the ankle, has also shown measurable analgesic effects in clinical studies. I want to tell you about Patricia. She was 71, a retired librarian from Boston. She had been living with fibromyalgia for 11 years. She had tried everything that conventional medicine offered: pregabalin, duloxetine, cyclobenzaprine, and yes, ibuprofen for her flares. And she described her life as managed suffering. She came to me not because she believed anything would help, but because her daughter had seen the Dr. Ming Chen channel and begged her to try. We started with a combination of curcumin with piperine boswellia extract and a course of weekly electroacupuncture. 8 weeks in, she called me on a Tuesday morning, which patients almost never do, and she said she had just walked to the park and back without sitting down once to rest. She cried on the phone. I will be honest, so did I, a little. Not because of the clinical outcome, though that was meaningful, but because 11 years is a long time to suffer in a world where alternatives exist. Now let me bring this together into a framework you can actually use. Chronic pain in Chinese medicine is almost always classified into one of four patterns. Cold dam obstruction, which presents as pain that worsens in cold and damp weather. Heat dam obstruction, which presents as red, swollen, hot joints. Qi and blood stagnation, which presents as fixed, stabbing pain that worsens with rest, and deficiency pain, which is the dull, achy, ongoing pain that worsens with fatigue. Each of these patterns responds best to different combinations of the approaches I have described. This is why a one-size-fits-all supplement recommendation is always incomplete. The goal is not to replace ibuprofen with turmeric mechanically. The goal is to understand your pain pattern and match the intervention to the pattern. Here is the broader truth that Chinese medicine understood and that modern pain neuroscience is rediscovering. Chronic pain is not just a peripheral phenomenon. It is a central nervous system phenomenon. It involves neuroplastic changes in the brain and spinal cord. It involves the autonomic nervous system, the gut microbiome, sleep quality, psychological state, and social connection. This is why the most effective chronic pain interventions are multimodal. They address multiple pathways simultaneously. The 6 alternatives I have described today are not meant to be chosen from a menu like a restaurant order. They are meant to be understood as tools in an integrated strategy that ideally includes movement therapy, sleep optimization, dietary anti-inflammatory intervention, stress management, and social engagement. When you put those pieces together, the results are not additive, they are synergistic. Here is your action checklist. These are concrete steps you can begin immediately. 1. If you are currently taking ibuprofen or another NSAID daily, do not stop abruptly without speaking to your physician. Have a conversation about transitioning. Ask specifically about your current kidney function and GFR. Get a baseline. 2. Introduce a standardized curcumin extract with piperine or phospholipid formulation. Look for a product delivering at least 500 milligrams of curcumin daily. Do this in the morning with a fat-containing meal for best absorption. 3. Research Boswellia serrata extract. Specifically, formulation standardized to AKBA content, which is the most active boswellic acid. This can be taken alongside curcumin safely for most people. 4. If your pain has a sharp fixed, stabbing quality, particularly joint pain, back pain, or pain from old injuries, speak with a practitioner about corydalis extract or nodo ginseng. These require more individualized guidance. 5. Find a licensed acupuncturist in your area and commit to at least 6 to 8 sessions before assessing effectiveness. 1 or 2 sessions is not enough to evaluate this therapy fairly. Ask specifically about electroacupuncture if your pain is musculoskeletal or neuropathic. 6. Eliminate the 3 dietary patterns that most reliably amplify inflammatory pain. Refined seed oils high in omega-6 fatty acids, refined sugar and high glycemic foods, and ultra-processed food products. This single dietary intervention can meaningfully reduce baseline inflammation within 4 to 6 weeks. 7. Get your sleep assessed. Chronic pain disrupts sleep, and poor sleep amplifies chronic pain. It is a vicious cycle. If you are sleeping fewer than 6 hours or waking frequently in pain, address this as a clinical priority, not an afterthought. 8. Move. I know that sounds almost insultingly simple when you are in pain, but controlled, progressive, low-impact movement, walking, swimming, tai chi, gentle yoga, is one of the most potent analgesic interventions that exists, mediated through endorphin release, improved circulation, and central pain modulation. The goal is not to exercise through pain. The goal is to find the movement that is possible and expand it gradually. Everything I have shared today is general medical information and is not a substitute for personalized medical advice. Before discontinuing any medication, before adding any supplement, already lincoln, especially if you are on blood thinners, immunosuppressants, or have existing organ disease, please consult your physician or a qualified integrative medicine practitioner. And to the community watching this right now, I know chronic pain is not a simple problem. I know it is not solved by a single video. But I also know that the information most people have been given about their options is incomplete, and that has real consequences for real lives. The Dr. Ming Chen channel exists to close that gap, to give you the clinical knowledge you deserve so that you can participate as an informed partner in your own health. If this video gave you something useful today, please share it. Leave a comment. Tell a friend who is living in pain that there are more doors than the one they have been looking at. Subscribe if you have not already, and I will see you in the next one.